think you could arguably do that with erlotinib too. I just think we do need to be mindful of the toxicity profiles, and I just think the data from that trial NEJ-009 should lead us to not be too haughty that we definitely know osimertinib is the way to go for everyone all the time. I think that we should start thinking about the EGFR mutation positive patients more as a campaign from start to finish over years, and trying to think of what's going to position them for the best treatment options like this trial did. We just kind of take a zero on that in the US, and I think it's partly market driven because PFS is easier to show and easier to sell. But I think that if I were the patient, I would care a lot about getting the best chance of living 5+ years. And that might be by giving a different EGFR inhibitor with chemo and then preserving osimertinib. I don't know. Right now, I think osimertinib is still a very strong choice because of the very favorable tolerability and efficacy and brain control, which is a real Achilles heel. I mean, if patients develop leptomeningeal disease, they can go down in a hurry. So I just think we should keep that as an option, and in parts of the world where you don't have osimertinib, it's a great choice. But I just would say we should stand back and not presume we know all the answers just yet. And ideally, try to get everyone, everything crossing over and see if there's a strategy that has more people alive in 4 and 5 years.
Okay. Questions from the audience?
Thanks for the great presentation. I have 2 questions. One is that just to summarize your perspective regarding PD-L1, the value of PD-L1 as a biomarker.
Yeah.
It appears that with squamous, non-squamous histology, regardless of PD-L1 status, there's a benefit in combination, but not much so with the non-small monotherapy of immunotherapy versus chemo. Could you just summarize?
Yeah, I think, I may be putting words into your mouth, but I think if you take a step back and ask the question of, do we even still need to do PD-L1 testing if the answer is always going to, if you're never wrong doing chemoimmunotherapy, can you just skip it? I think that is you wouldn't be wrong doing chemoimmunotherapy. I just have, one thing we didn't get into the weeds about is, because it wasn't really from ASCO, was in KEYNOTE-189, the 1-year survival with the chemo-immuno combination is 73%. It's 70% with pembro monotherapy in 024. And those are about the same. My inclination, and I would underscore it as just my inclination, there's not a wrong answer with the positive phase 3 trial to support it, is if patients have not wildly growing disease and a huge tumor burden, I would favor doing them sequentially in a high PD-L1 patient, because if I can spare someone ongoing chemo for years, then that would be my preference, and theirs. I mean, one of the real promises of immunotherapy initially was we could maybe get rid of the chemotherapy and have people doing really well without it. That's not the case. I mean, I would say, ironically, between KEYNOTE-407 and the New England and the NEJ-009, the Japanese study with gefitinib, chemo was the big winner. Who'd have thought? I mean, that's. But we haven't gotten rid of chemo yet. But I think that for patients who are not very symptomatic and don't have a lot of disease progression, I'm talking about you can sometimes tell, if patients are losing weight in the 3 weeks between their initial presentation and the time they see you and get their PET scan, or between their initial ER CT and the PET scan to complete their staging, and the disease has doubled in that time, you're not going to have a lot of time to futz around and have them progress. And if that's the case, I would give them chemoimmunotherapy and just make sure you get them that opportunity with both, hedging your bets. The best response rate is with that. But if there's a good chance that they are going to respond well to immunotherapy and the chemo is just along for the ride, I would rather not give them 2 years of chemo just vestigially. with all the expense and cumulative toxicity. I'd rather know what's working and what's not. And the best way to do that is to do the chemo and immuno separately for patients who have, not that big a disease burden and can handle it. So I think that it's more helpful for the PD-L1 highs, I think, then those are patients who I would spare the chemo if we can. I think we may still need to learn more about the negatives as well. That maybe tumor mutation burden will help us figure out which patients should or shouldn't get immunotherapy at all. There will be other biomarkers. It's not an ideal marker. I mean, even high PD-L1, it's not a 90% response rate, it's a 45% response rate. And that's not amazing. It's just better than not having it.
If you have a few more seconds, my second question, thank you very much for that answer, is regarding the crossover issue that you mentioned.
Yeah.
Which we see that becoming more issue. We had studies in head and neck, gastric, failing to show survival benefit,
Yeah.
potentially because as the ITT analysis design increases, so any comment on future design of the studies to potentially avoid? How would you?
No, I think the best thing to do would be to include crossover as much as possible. I really think that, I chastise the Keynote-042 trial. I mean, denying patients a survival benefit producing clear standard of care, at least in the US, and relying on 80% of people not getting that to make your first line treatment look good is not my favorite approach. I think if you can't look good still by giving your drug first rather than sequentially, I think it needs to be separating the question of timing versus access. And with the Japanese study with gefitinib, it shows it's about timing, that these drugs given together early may be really better. We've seen that with prostate cancer. Giving chemo with earlier setting of metastatic disease has a greater impact. So I'm beginning to come to that mindset that timing may really matter, and that giving it early may have a disproportionately greater benefit than giving it late. And if a study allows crossover, it still looks better, I'm really impressed by that, and I think that should inform our decisions more than just taking a zero on asking what happens after the first line in patients who are living 3 years and can get 4 lines of therapy.
Okay, we have time for one more question. Anybody with a question?
In squamous cell patients, do you have any thoughts on Abraxane versus Taxol? I mean, theoretically, you can use less steroids with Abraxane. Do you think that makes any difference?
I haven't seen any data from 407 to suggest that the steroids make much of an impact. I personally do use nab-paclitaxel, but I would just say it's a preference, and I would not ever say that it's wrong to do standard paclitaxel, especially if you're being cost conscious. But if we were really worried about cost consciousness, we wouldn't give years and years of immunotherapy all day long. I don't think it's going to come down to the 4 treatments with nab-paclitaxel as making this an expensive regimen. But no, I don't. I would say there was a study at ASCO from Memorial that looked at their data along with Institut Gustave Roussy and showed that results were not as good in patients who got checkpoint inhibitors who were on daily prednisone or at 10 milligrams or higher ongoing. It's not clear whether that is because they were getting steroids or because they needed steroids. People who needed steroids for brain mets or weakness and low appetite tend to do worse anyway. But it does lead us to have some concerns about that. But I would say we should not worry that this means you can't give pre-medications, because it's not like Keynote 189 looked bad with the pemetrexed pre-medication, Decadron. So I think a few days or doses of steroids is no big deal in the scheme of things. So I would just do whatever you felt like doing before for your squamous patients.
Thank you very much.
Sure.